Okay, let's do some pediatrics. This is bread and butter emergency medicine. These kids come into the emergency department all the time, and we need to basically have a consistent approach, knowing where we're going to go and how we're going to do it most effectively. You need to know, obviously, the definition of a fever. It's been defined as 100.4 rectally, and I have found, actually, having a son that just had a child 2.5 years ago, that there was a substantial reluctance to put anything in that kid's butt. And so, you know, he would call me up and say, yeah, I got it in there 1/4 of an inch. Because 1/4 of an inch, you know, you're not going to know anything for that, you know. But young parents, new parents, they were afraid. But the fact is, when we have these kids, we need to know whether that 100.4 has been reached, because if it has, we go down a totally different pathway than if it's not there. So if a kid's got 102, it really honestly doesn't matter whether it's 102, 104, 106, honestly. It doesn't tell you what's wrong with the kid, the height of the temperature. Some people believe that the higher the temperature is, the more likely that this kid has got a bacterial infection. That's untrue. The vast majority of kids who've got 104.8 have a viral infection. And yes, there's a little creep in terms of the number of kids who have a bacterial infection. But since these immunizations for pneumococcus and H influenza, you know, their bacterial causes of diseases are really down. In any case, there's this anxiety. You got to deal with it when the parents are at home. What if they say, you know, my kid had a temperature at home, but it comes in the emergency department, doesn't have it now? That's been looked at in the literature. And you know, speaking of the literature, in the past, people have said, well, where's the factual database from what you guys are talking about? You know, there's no references in the book or anything like that we're talking about. We have emergency medical abstracts, that thing out that we do. We have 15,000 abstracts in there. It basically, when we talk about stuff in the database, that's what we're talking about, in addition to independently reading these protocols from these various organizations. But it's kind of like an essential to know. And so the literature basically says, if mom said they got a fever at home, and they bring a kid in if they don't have a fever now, take the mother's word for it, particularly when you're dealing with a child less than 3 months, because the stakes are relatively high. You know, and because of their fear of sticking a thermometer up a kid's butt, they also come up with all of these other kinds of thermometers. You know, an axillary, and it's got a strip for the forehead, and you got this and that. One of the most accurate, I think, is this tempo thermometer. I don't know if you've seen that, basically. That does the job. That's accurate. But some of this other stuff, you know, nobody wants... I'm not interested in an axillary temperature. I need to know whether this kid's got a fever or not, because that tells me, and it tells mom, that there's something objectively we've measured that indicates that this kid has some illness. It may not be a serious illness, but this kid has an illness. Fever phobia is one of the things that we help create, and the literature is pretty kind of full of fever phobia. Even in some of the lay newspapers, they talk about this undue concern that we have created over fever. And one of the things that we do to create fever phobia is come up with this concoction of, well, we're going to alternate Tylenol and ibuprofen. And that sends the message, well, this must be pretty serious if we're going to do that kind of thing. And the AAP specifically says, don't do that. I know that some of you do that routinely, but it's not a great idea, because the fact of the matter is that when you compare acetaminophen and ibuprofen, ibuprofen may last a tad longer and maybe a tad more successful in bringing down high temperatures down a little bit. But the fact of the matter is that that drug is an antiplatelet. You're inhibiting your platelets. It decreases renal blood flow. None of the things that Tylenol does. So, you know, pick one, stick with it, but don't send this message that we got to do this commando behavior to get this kid's fever down because we're very concerned about it. There are a lot of people who make the case that fever is a good thing to do. It's a physiologic process. It was developed by the body to try to kind of deal with infection, and it's been shown that the fever does something that related to iron that has got something to do with suppressing bacteria. So the idea of suppressing fever just to suppress it maybe not a great idea. So the idea here is we give something for fever to make the kids feel more comfortable, but that's largely it. We talked about the idea of febrile convulsions. I don't think we need to review that again. Remember, it's the rate of rise, and because the rate of rise is there, by the time it gets here, you've already survived the transition from normal to high. So that's one of the reasons why it's very, 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 very difficult to prevent febrile seizures, because you never know when the kid's in this transition. And one of the things you often see in emergency department is, oh, the kid's got 104, they put it in a bath, and there's all these cooling measures done and all this. Have you ever seen any of those kids seize when they were in the cooling thing at 104? It's very, 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 very unusual, because they've already gone through the stressor that would have precipitated the seizures in most of the cases. So this is out of the American Academy of Pediatrics newspaper talking about fever phobia. So please don't be a source of creating fever phobia. Obviously, these kids, they can be encouraged to take more fluids. That's a great idea, because they are going to be generating heat. One of the things that's pretty obvious is, and you can see it even in adults particularly, when an adult is shivering and they're getting underneath the blankets, and that means the temperature is going up. When adults are flushed and sweaty, that means the temperature is going down. That's, it's very physiologic about how that occurs, but it's a good thing to know, because it's nice to see somebody kind of flushed and sweaty, because that means your Tylenol or whatever you gave is doing a job and temperatures are coming down. This fear about brain injury, and you need like 108 fever or something like that to even consider some brain injury issues, so that this is really not a concern. The mothers and the parents may be, so your job is to kind of reassure them that it's not dangerous to have a fever, and in many ways it may be a good idea from a bacteriologic, physiologic point of view. So we're really interested in the kid's behavior. We're into finding the source. As soon as they bring that kid to us with a fever, our job is to find the source, to see if there's something treatable. Fortunately, a lot of parents are smart enough not to bring the kids with fever to us all the time. There are 7 febrile illnesses a year in kids, and the vast majority of them obviously just go away without your intervention whatsoever. So we're looking for the source. And when I was younger, the source was always about occult pneumococcal bacteremia. And there was an algorithm that was developed by a guy at UCLA, a friend of mine, who I thought was basically a mistake, but it was very well accepted all over the country. So basically what you would do is a kid came in with like 103 fever, you couldn't find the source, so you would get a CBC. If the CBC was over 15,000, then you would then get blood cultures drawn, and they would be put away. And if the kid looked well, he would get a shot of ceftriaxone and be sent home. And by the time the blood cultures came back, which were generally normal, then everything was cool. So there was this 55-gallon drum of ceftriaxone in the department. And those of you who are old enough to remember this, there was a lure lock, and everybody's getting a shot of ceftriaxone kind of thing. Thank God we don't do that anymore. That was a mistake then. But the people who helped us were the immunologists, the people who came up with the influenza vaccine and the pneumococcal vaccines. Basically took all of that stuff and put it behind us. There's no pneumococcal bacteremia of any consequence then. And even then, most of it cleared by itself, because when the culture was positive for pneumococcus, and we would call the mother back, bring the kid back in, kid was generally feeling fine. We would repeat another blood culture. It was normal. So whether or not it was something that was really, really, really a problem, that was then. Now, since there is no pneumococcal, we had to come up with a new way to find what was going on in the febrile kids. One of the things that I think is really important to be aware of, and this is done all the time, is to blame a fever on an ear infection. It's done all the time. Here's the problem I found, it's an ear infection. Have you ever considered the fact that an ear infection is a little abscess behind the tympanic membrane? Why would that warrant 103 fever? You've seen abscesses on people's butt that are as big as your hand. They don't have 103 fever, but you're willing to say this is the cause of 103 fever? It makes no sense whatsoever. So, but it has been so easy for us to say that over the years. Oh, here's the problem. You know, there's always one eardrum that's more red than the other, and we made it up anyway a good deal of the time because we were desperate to find some reason to give this kid antibiotics to make us feel better. So we said, oh, it's an ear infection. And everybody knows that when you have an ear infection, you get antibiotics kind of thing. That's what all the other doctors did. Aren't you going to do that too, doctor? So, but the evidence on this is compelling. It's not. It doesn't. Well, the kid could have a viral infection that causes 103 fever, and concomitantly have an ear infection. But the ear infection did not cause that 103. That virus caused that 103, because you know of no other model in medicine where this tiny little thing there causes a problem. What is it? Because it's close to the, what is that temperature sensor in the brain? Is it like a direct wire that goes from the ear to the temperature regulator? I don't think so. So I know that taking that away from you will bother a lot of you, but you can do it. It just isn't right. So we have to find more sophisticated causes of fevers in children. Less than 3 months, we can't examine them very well. So basically, there's some algorithms with the febrile kid less than 3 months. And after 3 months, we say, we think we can determine whether the kid's toxic or not. And we can use more clinical judgment. We use less judgment under 3 months, more after 3 months. Not everybody agrees on what algorithms to follow. You could be in the, we got to find the urine infection algorithm, which I think is going to become the pneumococcal algorithm, pretty soon, and I'll show you some of the evidence about that in terms of that ought to go away. There are in your book 3 pages of algorithms that I got from Hennepin on how to approach these kids, and we're not going to take the time to go through them. On the ride back in the plane, read those 3 pages, and you will nail the psychology of how to track what to do based on the age of the kid, the temperature, what you can find. And this is all about source unknown. If you find the kid's got a cellulitis or a pneumonia or a pharyngitis, a strep throat or something like that, fine, you found the cause. And the likelihood of having 2 causes of an infection at the same time, extraordinary, rare, very, very rare. Be satisfied if you find one. So, I don't want to go with this. No. Let's just stick with the philosophy here. Here's a bunch of causes of kids who look bad, who don't have infections. I don't want to go through that list either. I want to talk about urine, because that's where we are these days. I don't know about your hospital, but a lot of these hospitals are sticking catheters in all these little girls as soon as they walk in the door, because the vast majority of them have viral infections. And because they have viral infections, you can't nail the source of this fever very well. So that means there's a low threshold for let's look in the urine. And if you look in the urine, the implication is this fever is coming from the urine. Is that right? Well, it must be coming from the kidneys. It must be pyelonephritis. It's not a bladder infection, because you all know that bladder infections don't cause fevers. So it must be pyelo that we're dealing with here. So let's go and find the pyelo. This is an article in Pediatrics that I really think that if you have access to, medical library, this is a great paper in terms of the background that it talks about and all of the facts and figures and things like that. One of the things to put in perspective is how many kids do they think, and I'm not sure that everybody would agree with this, has a source unknown fever, and the cause of that source unknown fever is pyelonephritis, and they say 5%, with 1 in 20. But the fact is, when you start looking at their data, it's even less than that. So 5% is what they said. One of the things we all know is if the kid looks sick, and you want to give them some antibiotics in the department, parenterally, you got to get a urine culture. And the only way to get a urine culture reliably in those circumstances is you cath the kid and get the urine and then give the antibiotics. For kids that you think are toxic and need something, I don't know the cause, but I'm going to get blood culture. I'm going to get a urine culture. I got my chest X-ray to see whether there's any pneumonia. I'm going to spinal tap, that's going to be up to you based on the circumstances. And we're going to culture all that stuff. And once that stuff is cultured, we're going to give something like ceftriaxone, and it's going to basically sterilize this kid while the cultures are growing. One of the things here that is absolutely true is don't even think of ever culturing a bagged urine. But there are things that you can do with bag urine. You can't. The idea of that the bag urine is no good anymore. We got to get pure urine out of. We got to put the suprapubic. We got to put a catheter in here, kind of thing. I don't know if you've seen very much of this, but moms don't like this. Dads don't like it when their little girls are being catheterized. They cry when they're being catheterized. And how many times have you seen some trauma down there? And next thing you know, there's a little bleeding down there. It's like, all for what? For what? Is it so important that we find this thing? I'm going to try to make the point that it's really not that big a deal. So they say the prevalence is 5%, which is 1 in 20 kids. So the other 19 basically get no value out of this process. We just don't know what 19 they are. But this paper, this from the American Academy of Pediatrics, says there are risk factors that you ought to consider in terms of determining higher risk or lower risk. And like, as an example, in the girls, if you have white race, that's not good. That's one, that might be one point. If you're less than 12 months, that's also considered a factor. If you got a temperature over 102.2, that's considered a factor. If you can't find another source, then those four things come into play. But look at the percentages. The probability of a UTI is 1% or less if you have no more than one risk factor. And then it goes up to 2% if you have 2% if or less if you have no more than 2 risk factors. So where do they get the 5% when they got 2 here? The same thing with the boys. One of the differences in the boys is the boys have to have a fever of 102.2 or higher for more than 24 hours. That's one of the distinctions. So and you're not going to certainly remember this stuff, but this is the kind of stuff that maybe you can go into some kind of ectopic brain in your pocket, just like all the reflexes and all that other kind of stuff that you may not be able to remember, because theoretically this is a big deal in terms of what kids are going to get catheterized, what kids are not going to get catheterized, what path we're going to go down. So basically, you have to acknowledge most of the girls and boys will be in a low-risk category, certainly less than 5%. So that being the case, if a kid's at low risk for having a UTI, this is what the American Academy of Pediatrics says. These kids can be followed. You don't have to get a urine on these kids. You don't have to even get a urine in these kids. We can just follow them. If the kid is not low risk, say they get a point or 2, maybe even 3 points kind of thing, then there's 2 options. And I think that these options are really important. The first option is to cath the kid, get the urine, and send it to the lab, or do a suprapubic tap. That's the first option. And Kevin Clower, who spoke here, that's his favorite. I, by far, like option number 2. Option number 2 is get a fresh voided urine and dip it for leukocyte esterase and nitrates. And if it's negative for both, that's not 100% guarantee that this kid doesn't have a urine infection, but it's darn good. If you get the urine and dip it for both and they're negative, then this kid can go home without anything further except potential for observation. Come back in a couple of days if the kid's still sick. That's it. The question then is, how do we get urine out of kids that is worthy of? So you want a high likelihood that your dipstick is going to be negative. You don't want any schmutz in there to kind of contaminate this thing, because once it's contaminated, once it shows that it's leukocyte esterase positive or nitrate positive, you got to go get the urine, which is not something you want to do, because the only way to get the urine is cath or suprapubic, except for 2 tricks that I'm going to tell you. One of the tricks, and this was actually published not too long ago, is a takeoff of a paper that paper that we did a long time ago. So here's the trick. So this kid is maybe 8 month old. You hold him up like a chicken. You get two hands around this kid and you hold him like a chicken. And you have take his diaper off kind of thing, and then you have somebody tap halfway between your umbilicus and the symphysis. You have them tap, one tap a second, one tap a second. And this paper, I forgot actually the yield, but it was extraordinary, the number of kids that peed at one tap a second. Well, obviously you have to have somebody ready to catch the urine. This is you may need 8, 9 people in the room to do this, but this is the nice way to do it. You know, you can clean, and the other thing is that you can clean up the genitalia, and if it's cool, that might be a trigger as well, but the tap works. The other paper that we saw a number of years ago is the kids laying down on the table. You clean them up a little bit, you tap on the belly laying down, and catch that urine kind of thing. And that's really going to be a nice clean urine. You dip it, negative for both, out the door with follow-up. I like this one. There was another one for girls who are older. Like if you have a girl who's like maybe 2.5 or 3, they sit on the toilet backwards, whereby they're facing the tank. And in the process of doing that, it spreads the legs apart, kind of thing, so the labia aren't glued together. And you clean them off. This is all done by mom, by the way. Mom cleans them off really kind of nicely. They sit there on the thing, and I can tell you that a 2.5-year-old will pee on command. Or else, you know. You want the catheter? No, they do. Okay. Basically, there is this entity called asymptomatic bacteruria. A lot of old ladies have it coming in from the nursing home, and one of the mistakes that doctors make all the time with these old ladies who comes in and they get the dwindles, and grandma's just not acting herself, and so that we do this extensive workup. We see this asymptomatic bacteruria. The woman has no symptoms of a urine infection. We see the bacteria. We don't see much in the way of pus cells. And we say, oh, here, I found the problem, and it's a urine infection. No, it's not a urine infection. So basically, you culture it. You're looking for pus. You're looking for colony counts over 50,000. It's generally E. coli. And then they're going to give you some suggestions about what to use here in terms of treatment. These are the recommendations of the AAP. If you're going to give a shot, they first make the point that a shot is no better than pills or liquid in terms of getting to where the action is here. Now, if the kid's vomiting and can't take pills, that's a different story. But we sometimes think like, a shot's going to do it. All these antibiotics are concentrated in the urine, so if anything, they're particularly good in the urine. So a shot, if you're going to give a shot, the thing that is most effective in terms of you only need to give it once in a day is ceftriaxone. When you look at oral antibiotics, the only oral antibiotics recommended by AAP given once a day is Suprax, Cefixime, which is only costs $300. Now, if you have some time to spare and want to give the antibiotic twice a day, you can use Bactrim, which is $19. You can hire somebody to give it twice a day if you look with the money that you save by not buying that stupid Suprax kind of stuff. So that was one of those are the Bactrim was the twice a day, or by far the most least expensive, and it works. Now, here's the whole issue. We have to find these urine infections because if we don't, they're going to destroy the kidneys, and all these kids are going to be on dialysis by the time they're 8 years old. Well, if this was really true, and for decades and decades and decades before we kind of looked at urine infections, if it was really true, there would be a lot of kids with a lot of screwed up kidneys because we never diagnosed urinary tract infections before like we are now. We think we are now. And yet, there's no kids on dialysis. I mean, it didn't do anything, kind of thing. Yeah, there are some kids who have problems with their kidneys in terms of mechanical reflux issues or whatever. And usually, after if a kid has 2 legit urine infections, well, maybe we'll try to find out whether there's some kind of mechanical issues going on there. But certainly, one. Here's the paper. This came out in Pediatrics in 2011. It's a review of 10 studies plus all of their own data, trying to say what's the likelihood that a urine infection could be the possible cause of a chronic kidney disease. And the number came out to be 0.2 to 0.3%, which is 2 in 1,000. 2 in 1,000. And this is possible. Whenever you see possible, it's like the word may. This may cause this. Whenever you have the word may, you can equally swap out the word may not. So, and since this paper came out, there have been other papers indicating that our great fear that this pilo is going to cause these kids to have bad kidneys is just unfounded. A little bit on the flu. We have 2.5 minutes for flu. So kids get flu, and the younger the kid, the more potentially problematic it is, and kids who have neurologic disorders and the flu are at particular risk of having sequelae, complications, and there's always the opportunity for some bacterial pneumonias to follow these viral infections. Flu lasts about a week, and you see this all the time. People say, oh, I get the GI flu. You should not aid and abet in that terminology. There is no such thing as the GI flu. The GI flu would imply that you're coughing out your butt. The flu is a respiratory illness. Yes, fever, myalgia, chills, weak, you feel tired, weak kind of thing, and gradually it moves up into your throat, and you get a sore throat, and your throat's irritated. You start coughing kind of thing. The younger kids may get some conjunctivitis. That's the flu. It lasts about a week. When you're dealing with, this got the season, you got the flu season. So the question is, should we be doing these quickie tests? Is there an advantage to doing them? Well, if you're in the middle of the flu season, and every soul who comes in the door has these symptoms that we just described, it's not a good idea to do these CLIA tests, because the CLIA tests that they have, when you look at the sensitivity, is 60%. That means you're going to miss 40% of the cases if you're going to depend on that quickie test during the height of the flu season when clinically everybody has it. So where these tests tend to be helpful? They tend to be helpful on the shoulders of the flu season to help try to determine it. They're going to get better and better over time, but the composite now is somewhere in the neighborhood of 60%. One of the things that is really good about them is their specificity. If it says you got the flu, you got the flu. That's it. You're done. That's it. So, and there is some, things in here about comparing it to physician judgment. Physician judgment, well, the idea here about rapid tests and clinical diagnoses are similar in producing false negative. A false negative. It says you don't have it when you really do, between the test and the doctor's judgment or your judgment. On the other hand, catch this other one. False positive results are 8 times more frequent with a physician's clinical judgment. 8 times more frequent false positive. You have the flu, you really don't. So we tend to overdiagnose. If we're going to overdiagnose, then basically we're going to be writing for that Tamiflu stuff. One of the things I think are potentially valuable out of doing these quickie flu tests, most people would say don't bother, but there's a couple of papers in our database that says once you know a person has the flu, with confidence, you'll stop doing CBCs, you'll stop doing UAs, you'll stop giving antibiotics, you'll stop doing chest x-rays, because that's what happens when you're not sure what's wrong. When I'm sure that this is the flu, all of that goes away. Nobody's getting ampicillin or Keflex or any of that crap because it's the flu. And once you say to the patients it's the flu, they know it's a viral disease kind of thing. You feel comfortable. So that's one of the potential positives out of this. There's a lot of controversy about whether Tamiflu does anything. There was a analysis of this a few years ago, and they said it knocked off a half a day to day and a half of clinical illness and a week-long disease if you got it within 48 hours. That was the mantra. Everybody believed that. Well, there's more and more and more stuff coming out that basically is discouraging about Tamiflu in terms of how well it works. It's $52 to give, and if it picks up a half a day, So the literature on this is really pretty controversial right now. And if you want to Anyway, it's pretty controversial. The Japanese have basically shown that this stuff does cause neurologic side effects in 3% of cases, and there was a great deal of difficulty getting the drug company to release the raw data on the Tamiflu studies because they don't have to release all of them. And the more they fought the release of their raw data to have their data reanalyzed independently, it's recently been released after much fanfare, and they're finding out that this drug is not nearly as good as we think it is. All right, so I think that's enough of this stuff. So that's febrile kids.